The moment a patient is finally discharged after a long stay in the ICU, the prevailing emotion is simple: relief. The medical crisis has passed, and they get to walk through those double doors and go home. Before they leave, the hospital provides a thick packet of discharge paperwork. It meticulously details exactly how to manage physical recovery. It outlines schedules for wound care, lists daily medications, and prescribes weeks of physical therapy. But weeks later, sitting in their own living room, many survivors notice a terrifying shift. They experience an unrelenting brain fog that makes simple tasks feel impossible, and they develop a visceral, panic-inducing dread at the mere thought of entering a medical building. None of this was in the discharge paperwork. That omission creates a massive gap between what the survivor expects recovery to look like and the deeply disorienting reality they are actually living through. The most alarming symptom usually strikes at night. Survivors wake up gripping the sheets, haunted by vivid, terrifying memories of things that happened to them in the hospital ward. Yet when they describe these events, their family members swear they never actually took place. Because no one else in the room saw or experienced these events, the survivor is trapped. They are left entirely alone to process a reality that everyone around them dismisses as a dream. Without a medical explanation for what is happening to their mind, patients draw the only conclusion that seems to make sense. They assume they are either failing at recovery or completely ungrateful for having survived in the first place. These psychological symptoms indicate an unaddressed medical condition, having nothing to do with personal strength or a lack of gratitude. Clinical researchers have a specific name for this condition: post-intensive care syndrome, or PICS. The intense stress of surviving a critical, life-threatening illness leaves lasting physiological and psychological marks on the body. These marks occur independently of the original disease or injury that put the patient in the ICU to begin with. This diagram illustrates what clinicians call a triad of aftermath. PICS simultaneously impacts three distinct areas of human function: thinking, mood, and physical ability. Under the thinking branch, the damage manifests as severe cognitive decline. Survivors struggle with memory retention, executive function, and a lingering brain fog that persists for months after discharge. The mood branch reveals the sudden onset of intense anxiety and clinical depression. Meanwhile, the physical branch shows sustained, profound muscle weakness and fatigue that regular physical therapy fails to resolve quickly. The interaction between these three branches shows how PICS systemically rewires a survivor's entire baseline function. This visual breaks down the statistical reality of critical care recovery. Out of every 100 ICU survivors, research shows that nearly a quarter of them will develop severe, lasting PTSD symptoms. The root cause of this trauma often stems from a condition called ICU delirium. The combination of heavy sedatives, sleep deprivation, constant alarms, and intense medical interventions forces the brain into a state of severe confusion, generating vivid hallucinations. The brain does not distinguish between a physical event and a chemically induced hallucination. It encodes those terrifying ICU delusions as real, legitimate trauma. Those sudden nightmares and startle responses at home are a normal neurological reaction to what the brain perceived as an extraordinarily dangerous environment. In critical care medicine, physical survival and psychological trauma are deeply intertwined. Doctors cannot fully treat one without eventually acknowledging the other. Recognizing this link requires a shift in how we view recovery. Exiting the hospital doors marks the end of the physical emergency and clears the way for the necessary psychological healing to begin. Clinical psychology offers specific tools for this. Modalities like trauma-focused cognitive behavioral therapy and EMDR have strong documented evidence behind them for treating medical trauma. Untangling vivid delirium from reality is complex work. It requires the targeted intervention of a licensed clinician who understands medical trauma, because simply waiting for time to pass will not clear the symptoms. Attempting to push through post-intensive care syndrome alone is like trying to fight off a massive bacterial infection without antibiotics. It is a medical condition that requires a professional treatment plan. This creates a frustrating paradox. The very people who need clinical help the most often experience crippling dread at the thought of driving to a clinic and sitting in another medical waiting room. The most effective solution bypasses that trauma trigger entirely. By conducting therapy through 100% secure, HIPAA-compliant video telehealth, survivors can process their trauma from the safety of their own home. This map illustrates the reach of Coping and Healing Counseling, or CHC. They have a diverse team of over 15 licensed therapists, including clinical social workers and marriage and family therapists, delivering telehealth coverage to all 159 counties in Georgia. To ensure this care is accessible, they address the financial barrier directly. For patients on Medicaid, there is a $0 copay. For those on most major commercial plans like Aetna, Cigna, or Blue Cross Blue Shield, sessions typically range from just $10 to $40. Surviving the intensive care unit secured your physical health. Reaching out for support provides the path to untangling the trauma and reclaiming your life. When you are ready, you can connect with a clinician at chctherapy.com or by calling 404-832-0102.